Hi, in this study, I'll be discussing functional references for tibial axial rotation in total knee arthroplasty. I'd like to thank the co-authors of this study. There are three key approaches to set the tibial axial alignment. So firstly, surgeons can use a rotating platform tibia, which can provide a dynamic tibial axial alignment. However, when using a fixed bearing construct, surgeons often resort to either the range of motion technique, which aims to synchronize the alignment of the tibial component with the femoral component, or more commonly, reference axes, based on which the alignment takes place. So, for example, there's Insel's axis, which is the line from the PCL insertion to the medial third of the tibial tuberosity, or Cobb's axis, which is perpendicular to the line that joins the two tibial wells. Despite these techniques, tibial malrotation still occurs and can contribute to pain, stiffness, patellar instability, as well as excessive polycomponent wear. The incidence of malrotation is about 2.3% in Australia in 2020. However, when we consider these aggregating factors, it may be as high as 30%. So what does literature tell us? Although the design of previous studies may vary, some common findings are 1. Excessive internal rotation, 2. Tibiofemoral internal rotation, and 3. Tibiofemoral rotational mismatch may all result in inferior patient and clinical outcomes. Since tibiofemoral rotational mismatch is a factor, it's important to consider the femoral reference during tibial rotational alignment. There have been prior attempts to establish femoral reference for tibial rotation. These involve projecting the TEA onto the proximal tibia using either 2D CT slices or 3D reconstructions of CT scans. However, these would provide the reference in a supine CT position, which many would not consider to be a functional position. So the aim of this study is to compare common tibial rotation reference axes, more specifically Insel's and Cobb's axes, to the projection of the TEA on the proximal tibia in the supine CT position, as well as the weight-bearing and extension-distracted positions. In terms of the methods, preoperative CT scans and an AP and extension-distracted radiograph were captured as a part of the surgeon's standard of care. The CT scans were segmented to create 3D reconstructions, which were then landmarked before being registered to the 2D radiographs. Anatomic measurements were then taken. These are representations of the two radiographs, weight-bearing AP on the left and extension-distracted AP on the right. The positions used for the TEA projection include the supine CT, like the previous studies. However, we also included the functional weight-bearing and extension-distracted positions. For comparative purposes, all axes were measured relative to Insel's axis. So Insel's axis was 4.84 degrees externally rotated to Cobb's axis, 9.67 degrees externally rotated to the CT TEA projection, 9.65 degrees externally rotated to the weight-bearing TEA projection, and 8.3 degrees externally rotated to the extension-distracted TEA projection. So overall, Insel's axis was observed to be the most externally rotated of those assessed. This poses a couple of questions. So 1, does aligning neutral to Insel's place us at risk of excessive external rotation? Or are we able to internally rotate relative to Insel's? And if so, how do we know how much to rotate by? We also note that the variability of the TEA projection measurements were consistent with existing literature, with the standard deviation being in the range of 4 to 7 degrees. Overall, tibial malrotation and tibiofemoral rotational mismatch can result in inferior patient outcomes. And so it's important to consider the femoral rotation during tibial rotational alignment. The work we have done is still in early stages. This study discusses an interpatient analysis, but we hope to continue the work and have a look at intrapatient variability and also consider the axes relative to post-operative alignment and link them to patient outcomes. And depending on the outcome of further research, we hope to incorporate the findings to influence alignments during preoperative planning and navigation intraoperatively as well. Thank you.